So, hi, good evening, all of you. So, welcome to this Farre session on dermatology, psoriasis, and lichen planus today. I'll just confirm if I'm audible and visible, and accordingly, I shall get the session started for today. If anybody could confirm in the chat box, that would be great. Hi, Fatima, good evening. So, can you please confirm if I'm audible and visible? So, if I'm audible and visible, yeah. So, how are things going? How is the preparations? How is Farre helping you? Okay. So, yeah, in today's session, what I'm planning to do is hopefully 2 days before, most of you have attended the classes. So, 2 days ago, we have done session on vitiligo and alopecia areata. So, both vitiligo and alopecia areata was autoimmune diseases in dermatology, correct? So, another very, very important topic that I would like to deal today is regarding psoriasis and lichen planus. I'm very sure during your clinical postings in the hospital, uh, every time if you go to dermatology department, you are bound to see a case of psoriasis, and so is lichen planus. Both are very, very common, and for the examination point of view also, it's a very, very important topic. So that is why I have chosen this topic for today. So now let's get started. Hi Sam, good evening. So now, yes, so we are updating it constantly, and I'm sure that you'll be getting the entire Pare booklet very soon as well. Okay, Shubham Pandey. So thank you so much for your responses. So as usual, since this is not a session that is meant for NEET PG or doing any kind of MCQ kind of exams. So right now this session is completely intended to help you to clear the final year MBBS, right? So whenever you get a question on dermatology, I just want you to be very clear on this. In case you have not attended the previous session, then please understand what are the expected exam questions on psoriasis as well as lichen planus. Okay? And also we will also try to learn how can we structure the written part of the answers, like how can you make it very much impressive to the examiner. Okay, and also we will learn key what exactly are the things that you should know from these diseases today. Hi Helixwaram, very, very good evening. So now let's start with the first topic of the day. It is psoriasis. Okay, in psoriasis, first let us see what are the expected kind of questions now. So again, it can be either a long answer question, है ना, या फिर short notes हो सकता है. Otherwise, it can also be a clinical scenario. I'll just read out some of the questions for you so that you understand what is the type of question that you're now preparing for. Okay. So imagine that you're getting a question like explain the clinical features and management of psoriasis. Direct question hai. There is no confusion here. The examiner is asking you the clinical features of psoriasis and along with that the management of psoriasis. So we need to know about both. Otherwise, discuss the pathogenesis and systemic associations of psoriasis. Or let us see this clinical scenario. A 35-year-old patient presents with scaly plaques over the elbow and knees, and outline the diagnosis and the management. Please update the systemic surgery Farre. Shubham, it is getting constantly updated. Okay, don't worry, because this is the first time that we are doing the final year for Farre, and it will be very soon completely updated. Okay, don't worry about it. So now let us see how do we get it started. Okay, did you guys understand when you read a question like this, scaly plaque lesion over the elbows and knees? So when you get something like that, what should come to your mind? It is going to be this disease called psoriasis. So now let's try to understand what are the important things that you should know when it comes to psoriasis, right? So now let me, one moment. So now, yeah. So now let us get started. So just like the previous session, always remember if it is dermatology, just try to go it in this order. You are always bound to give a short introduction. Like for example, if the question is about psoriasis, try to give at least 1 or 2 sentences about what is psoriasis. Even if there is some disease that you may not know, even you know that okay, ये एक vesiculobullous disorder है, या फिर ये एक plague type of disorder है, just at least write down कि this is a plague disorder, this is a vesiculobullous disease, or this is an infection, bacterial infection, viral infection, etc. So always important that you give a short introduction of what is the topic, and after that we will go it in this order: etiology and pathogenesis, followed by the clinical features, differential diagnosis, and finally management. So this is the order how you will go for any of the diseases or the questions that you get in dermatology. Clear? So now let's move to the first one. Now let us first see what are the things that you know in psoriasis. First of all, what is psoriasis? So can psoriasis spread from one person to the other? And what type of disease is it? Is psoriasis something associated to autoimmunity like vitiligo, alopecia areata, which we learned in the last class? Or is it something else? So first thing, again, remember, always try to go to give a small introduction. Okay, you are going to give a small introduction. So in this introduction, the first thing that you can always relate is it something that is acute as in infections? Yeah, is it a chronic disease? I guess this is very simple for all of you to know. Is psoriasis is going to be a chronic condition, isn't it? So please write down that psoriasis is a chronic. So what type of chronic? It is an immune mediated inflammatory disease. Chronic immune mediated inflammatory disease. Okay, this is a immune mediated inflammatory disease. Hi Kalai, good evening. And second thing, we can also mention ki how will usually a patient of psoriasis present to you. So you can also mention that it usually presents with any answer for this one. Does the patient present to you with vesiculobullous lesions, or does the patient present to you with plaque lesions, or does the patient present to you with macules or patches? Can anybody answer in the chat box? Let us try to make it little more interactive. है ना? So how does the patient present to you with psoriasis? Is it vesiculobullous? Is it plaque lesions, or is it macules and patches? Anyone in the chat box, please? The patient usually presents with, should I give the answer? The patient usually presents with plaque lesions along with silvery white scales. Silvery white scaling. Now what is happening here is, in this sentence, what is giving you the mark? The plaque lesion is giving you the mark, and the silvery white scaling is also giving you additional marks, because these are exact keywords that the examiner will be looking for. Correct? So that is about a short introduction about psoriasis. And psoriasis, yeah, very good. Yeah, Kalai is adding one more. Okay, chess with Somi, Kalai, Fatimatun, Nisa, all of you are answering it. Very good. These are all plaque lesions. And one additional point that Kalai has added is it is usually seen over the extensor surface. I agree with you. But what I'll do is I'll talk about it when I go into the clinical features of this disease. Okay. So now let's jump into the next one. So after that, what you write? You write about the etiology, or you may write about the pathogenesis. Now here, I have already told you that this has nothing to do with autoimmunity, correct? So instead of autoimmunity, what is happening here? It is an immune mediated inflammatory disease, right? So here you can write, this is going to be multifactorial. This is going to be multifactorial, because as we have already written, this is going to be a immune mediated inflammatory disease. So we have just repeated the same sentence which we have written now. So this is an immune mediated inflammatory disease. And other than that, is there any HLA associations that is associated? So this HLA wala thing, if you can give it very specifically, that is going to be again an additional mark for you, isn't it? So you can just write down, there is a genetic predisposition. So under this genetic predisposition, you can write down what are the two types of HLA that is associated with this disease. So anybody in the chat box, what are the two types of HLA that is associated? The first HLA is going to be something that is associated with early onset disease or very extensive disease. So let us say juvenile psoriasis, early onset or very severe and extensive disease. HLA-B27 is one of the answer which I'm getting. So HLA-B27 is also right. But please remember, HLA-B27 is not associated with early onset. It is associated with pustular psoriasis. It is associated with pustular psoriasis, as well as it is associated with one more, psoriatic arthritis. Psoriatic arthritis. Clear? Yeah. So yeah, not HLA1. I would say the other one is HLA-CW6. Okay, the HLA-CW6. Yeah, Fatimatul Nisa has answered it. It is HLA-CW6. Very good. So what is HLA-CW6 associated with? It is associated with early onset disease and severe disease. Early onset disease and severe disease. So please remember these very important points. Like one is it is immune mediated inflammatory disease. The second one is that this is associated with some genetic predisposition to HLA. You will remember HLA CW6 and HLA B27. CW6 is associated with early onset and severe disease, and HLA B27 is associated with pustular psoriasis and psoriatic arthritis. Clear? So now, after writing a few points regarding the etiology and the pathogenesis, now we have to just move into the next one, like what is the clinical presentation. Now in clinical presentation, I always would love to add the clinical presentation along with the images, even though you cannot put images in your answer paper, but yes, try to learn dermatology with images. It is much more easier. It is much more easier. So now I'll give you a simple way how to remember this types of psoriasis. Now let us write down the first type of psoriasis, and the first type is going to be acute guttate psoriasis. So this one is going to be acute guttate psoriasis. So wherever there is an acute presentation, there can be a chronic presentation as well. All of you agree with me? जहाँ पे भी acute है, there is a chance for a chronic presentation as well. So the second one, just write down that this is chronic plaque psoriasis. तो easy है, एक हो गया acute, दूसरा हो गया chronic, correct? So in acute, so what usually happens in acute thing? Something that is happening all of a sudden. And what happens all of a sudden? It can be either a trauma, है ना, कोई injury हो सकता है, या फिर कोई infection हो सकता है, correct? So this one here, this acute. So when I say about acute, I mean that this is associated with, so this is associated with infection. So this is associated with infection. Now anyone, can you tell me what is that infection which acts as a trigger for acute guttate psoriasis? Because क्योंकि in the start of the session मैंने बोला कि psoriasis is not an infection. Psoriasis कोई infection नहीं है, इसीलिए it cannot be passed on from one patient to the other, correct? But there is one type of psoriasis which is going to be associated with an infection. So I guess we have the answer already in the chat box. So the answer, right answer here is, this is associated with group A beta hemolytic streptococcus. This is associated with group A beta hemolytic streptococcus. So when I say beta hemolytic streptococcus, what is the usual infection? This is usually seen after a sore throat. This is usually seen after a sore throat. I'll just rub the second name. I'll just write it again and just needs little more space. So this is seen after a history of a sore throat. अभी patient कैसे present करते हैं in acute guttate psoriasis? The patient would always present to you with complaints of multiple small erythematous plaques. Okay, the patient can present to you with multiple small erythematous plaques. That is how a patient can present to you with acute guttate psoriasis, and this one is also compared to a raindrop psoriasis. This one is compared to a raindrop psoriasis. Why raindrop psoriasis? Because you can see that in this image there are multiple small erythematous plaques. When did the patient develop these erythematous plaques? After within 1 week of having a sore throat, that acted as a trigger. After that, the patient is getting multiple lesions like this is coming to you. Your answer is acute guttate psoriasis. Clear? So now let's move to the second one. The second one, as I have listed down earlier, the second one is called as chronic plaque psoriasis. Now, this chronic plaque psoriasis, during our last session, I told you that what is the most common type of psoriasis? We use something called vulgaris, correct? So this one is what we call as psoriasis vulgaris. So this is the one which we call as psoriasis vulgaris. Now in this image, I'm just zooming this image for you. Now where do you find this lesion here? The patient is having these lesions over which surface? Is it flexures or extensors? This image, like what you can see, this is the image that you can see. So in this surface, you are having the lesions. And this lesion, what is it? This lesion is called as, what is it called? Yeah, this is going to be extensor surfaces. So please write down that psoriasis vulgaris, or the chronic stable kind of a psoriasis, chronic plaque type of psoriasis, this is going to be seen over extensor surfaces. It is seen over extensor surface. Is seen over extensor surfaces. Is that clear? And obviously, as you know, how do you find these lesions? You can find these lesions. How do you see these lesions? Anyone? This is going to be erythematous plaque. Yeah, erythematous plaques with silvery white scaling. Erythematous plaques with silvery white scaling. So that is how you can see these lesions. Clear? So now let's move to the next one. So in this next one, you can see that we have done with two. The first one that we have discussed already is going to be, what is the first one that we have discussed? The first one that we have discussed right now is acute guttate. The second one that we have discussed right now is chronic stable plaque. So now let's moving to the next one. What you can find here. So what do you find here? Yeah, so now you can see that there is the involvement of the palms and soles. So with the involvement of the palms and soles, we call it as palmoplantar psoriasis. Palmoplantar psoriasis, where you get psoriatic plaques over the palms and soles. Where you get the psoriatic plaques over the palms and soles. Clear? So that is all about this kind of psoriasis. Now moving to the next one. So in this next one, a minute. So moving to the next one, you can see that this is a fourth type of psoriasis. So what is happening in this fourth type of psoriasis? In the fourth type of psoriasis, you can see that this is the area where you can find the lesion. That is over the flexural surfaces, not the extensor. So whenever, rarely the patient presents to you with psoriatic lesion over flexures, we call it as flexural psoriasis. Flexural psoriasis. Or we can call it as inverse psoriasis. Inverse psoriasis. So this is where psoriasis with lesions over flexures. These are the various clinical presentations of plaque type of psoriasis. Okay, these are the different clinical presentation of plague type of psoriasis. Yes, so there is very minimal scaling. So more than scaling, what you can see is there is a erythematous plague here. There is a erythematous plague here. Now, just moving on, how many of you think that psoriasis is only going to present to you with plaque lesions? Or is there any other type of psoriasis which is possible? So, can psoriasis present only with plaque lesion, or is there any other type of lesion also possible? That is my question. So, what is your answer? So, how many of you think that this is only going to be plaques? So, any answer? Yeah, so this one, just adding on to it, we have just written about 4 type of psoriasis. So please add on. There is also pustular type of psoriasis. So the 5th and the 6th one is going to be pustular type. So don't forget about it. Psoriasis can also present to you with pustules. So this one, the pustules can be either localized or it can be generalized. So it is easy to remember. The first one is going to be localized. Hi Nishan. So this one is called localized pustular psoriasis. And the second one is called as generalized pustular psoriasis. So what are you going to see when it comes to a localized psoriasis? This is going to be localized somewhere in the body. Now just see this image and tell me, where are the pustular psoriasis localized to? Why did I give you the image of palms? Because this is going to be localized to the palms and soles. Okay, so this is localized to the palms and soles. Now, psoriasis is not an infection. Whenever we see this pustules, we always think that, okay, ye pustule hai, so most probably this can be because of a bacteria and we will be sending it for a swab. So once we send the swab for investigation, what is the result that we are going to get? Will it be positive for a bacteria? Will it be positive for a fungus? Yeah, is it going to be a sterile pustule? Any guess, all of you? What is it going to be? Is it going to be positive for bacteria? Positive for fungus? Yeah, is it going to be a sterile pustule? What's your answer? Now, all of you, please remember, these are going to be sterile pustules. So these are going to be sterile pustules. So that is going to be your most important point here when it comes to localized pustular psoriasis. Clear? So now moving ahead to see what is generalized pustular psoriasis. Generalized pustular psoriasis, just like what the name says. Yeah, Helix, it is going to be sterile. So just like what the name says, this is going to be generalized throughout the trunk. This is going to be generalized throughout the trunk. That is going to be the first important point. Here also you can see sterile pustules. Sterile pustules. And this is going to be compared to a lake of pus. So this is going to be compared to a lake of pus. Now remember that this generalized pustular psoriasis, this is also having one more name, and that name is also important. This is called as von Zombush reaction. So this is another name of generalized pustular psoriasis. So why do we call it as a von Zombush reaction? Because this is usually seen when a psoriasis patient is treated with systemic steroids. So this is usually seen when a psoriasis patient is treated with systemic steroids. Because just keep this point in your mind. I'll just explain to you about it in some time. Yeah. Now all of you who are attending the lecture right now, so what we have done so far, I'll just have a very quick recap. So when you talk about the clinical features of psoriasis, what you need to mention is that in the clinical features of psoriasis, the most important thing is there are 4 types of plaque psoriasis and 2 types of pustular psoriasis. What are the 4 types of plaque psoriasis? Acute form, acute guttate. It is associated with streptococcal sore throat. After acute, there is always a chronic. Chronic is the most common one. This is the most common one. That is why we call it as psoriasis vulgaris. Patient presents with erythematous plaque with a silvery white scaling. And then the next one is when we have only lesions over the palms and soles. Over palms and soles, what do we call? We call this one as palmoplantar psoriasis. The next one is when you get lesions over the flexures. When you get it over the flexural aspect, we call it as inverse psoriasis or flexural psoriasis. And then in pustular psoriasis, there are 2 types. One is localized again to the palms and soles. The other one is generalized. Generalized matlab, it is going to be generalized throughout the trunk. It is going to be generalized throughout the trunk. Yes. So yeah, Kalai, pregnancy maybe we can see psoriasis. In pregnancy, as you said rightly, the psoriasis which we can see is the pustular type. Again, the generalized pustular type of psoriasis. It's also called as impetigo herpetiformis. Completely agree with you. So now let's jump into some of the clinical signs. Remember last time also, along with mentioning the various clinical features, we always add these clinical signs as well. So what is the clinical sign that we are going to discuss now is there are 2 very important clinical signs. The first clinical sign, which you can always mention in your answers, is going to be Auspitz sign. So this can be Auspitz sign. So any idea what is an Auspitz sign? So what is Auspitz sign, all of you? See, just imagine the patient is having a plaque lesion over the elbow. Okay? And I'm taking a glass slide. And I take a glass slide and I'm going to scrape over the lesions now. So once I scrape over the lesions, when I continuously scrape over the lesions, what do I see? I can see that the scaling has disappeared and the patient is developing multiple small bleeding spots like this. So these bleeding spots which develop on scraping this lesion, this is called as Auspitz sign. Okay. So what is happening in an Auspitz sign is you are not directly seeing an Auspitz sign. The Auspitz sign, you are actually doing something over the lesions so that you elicit the sign later. So scraping over the lesions, scraping over the lesions produces pinpointed bleeding spots. So scraping over the lesions, it produces pinpointed bleeding spots. This is called as Auspitz sign. Now, when we learn about Auspitz sign, let us also write down what are the stages of this test. Okay. So first thing what you do here is you can see once you take a glass slide, you take a glass slide and you are going to start scraping the lesions. So once you start scraping the lesions, the first thing that you can see here is there is a accentuation of scaling. So what do I mean by an accentuation of scaling? ये जो scaling था जो lesion के ऊपर, that scaling that becomes much more visible once you start scraping over the lesion. So this one, the first step is called as grattage test. This is called as grattage test. Okay? Now, once you continue scraping the lesion, once you continue scraping, you can see that there is a shiny membrane that develops. So this shiny membrane that develops, this is called as Bulkley's membrane. So this is called as Bulkley's membrane. And once you again continue scraping the lesion, so once you continue scraping the lesion, what happens? Then you can see Auspitz sign. So if there is any queries, you can just let me know in the chat box. So this is how a auspicious sign is elicited. So there are basically 3 steps to it. So once you start scraping the lesions, first kya hota hai? The scaling becomes much more visible. So what do we call for that? Grattage test. Then when we continuously scrape, what happens? A shiny membrane will develop. And what do you call for the shiny membrane? The shiny membrane is called as a Bulkley's membrane. And again, you're not stopping. You're continue to scrape. Once you continue to scrape, you see something like this, bleeding spots over the skin. So this is called as the actual Auspitz sign. Is that clear? Now, the second one is this one. So regarding this image, who can answer me what is this? What is this second clinical sign? I'll give you a simple example कि क्या हुआ है इस patient में. The patient has scratched over the skin. After scratching over the skin, the patient has developed new plaque lesions over the skin. So any answer? After scratching over the skin, the patient has developed some plaque lesions. Anyone? So I would be waiting for your answer, because even if you have attended the last class, I told you whenever there is a new lesion which develops on trauma. Yes. So this one, yeah, I got the right answer in the chat box already. Thank you so much for answering. So this one is called as Koebner phenomenon. Okay. New lesions appear on trauma. The new lesions that is appearing on trauma, because last day we learned that in vitiligo you can see Koebner phenomenon. So today I'm adding that in psoriasis also you can find Koebner's phenomenon. There are actually 3 diseases which you should remember for Koebner, that is lichen planus, vitiligo and psoriasis. Okay, lichen planus, vitiligo and psoriasis. So now let's move into the next one. So we move into the histopathology, because in psoriasis what happens, whenever you wanted to go for a confirmation of the diagnosis, we definitely will do send the patient for a skin biopsy. So when we do a investigation for of called as skin biopsy, we will be able to elicit the histopathological features of psoriasis. So what you see in psoriasis are multiple findings. So all these findings are mentioned here. The first one is parakeratosis. Parakeratosis means there is a presence of nucleus in stratum corneum. So important finding is going to be parakeratosis. Another very important finding is microabscess. So what are the 2 microabscess? At least remember these microabscess by its names. Okay, there are 2 microabscess you are going to definitely remember. One is Monro microabscess. Monro microabscess. The second one is pustule of Kogoj. So these are the 2 microabscess which you can see over the skin or in the histopathology of a patient of psoriasis. So these are the 2 features that you can see in the histopathology of a patient of psoriasis, that is Monro microabscess, pustule of Kogoj, whereas we can also see the presence of nucleus in the stratum corneum. What is it called? This is called as parakeratosis. And along with that, you can see multiple other findings also, like suprapapillary thinning and all. But at least do mention about microabscess. This is going to be a very, very important finding. Yeah. Now, coming to the differential diagnosis. What are the differential diagnoses of psoriasis? So what are the different diseases that can mimic psoriasis, or which you find as a very close clinical differentials? Anything? See, one disease like where you get an acute guttate psoriasis, a patient who is having sore throat and developing acute guttate psoriasis, there is one more disease which is having a very, very similar clinical presentation. That is going to be pityriasis rosea. That is going to be pityriasis rosea. The second one is going to be, because you may get multiple rounded plaque lesions, the another confusing thing can be tinea corporis, like what we call for the ringworm. Okay, what we call for ringworm. Another one, it can be eczema, discoid eczema, etc. So many other differential diagnoses can be seen. Okay, so now let's move into the finally the management of psoriasis. Now, who knows how can we manage psoriasis? Can anybody answer in the chat box? Okay, what are the drugs which we can use for the management of psoriasis? How many of you can answer? Drugs which can be used for the management of psoriasis. Any answers? Anyone? Uh, I'm just waiting for your answer in the chat box. Anybody? What are the drugs that we can use for the management of psoriasis? So remember, just like in the last chapter, how did we go? Whenever we do any treatment for dermatological conditions, there are always topical agents or creams. Okay, first let us write down about topical agents. जी, तो फर्स्ट हमें क्या यूज करना है? टॉपिकल एजेंट्स यूज करेंगे, है ना? तो व्हाट आर टॉपिकल एजेंट्स? टॉपिकल एजेंट्स का मतलब क्रीम्स हो सकता है, ऑइंटमेंट्स हो सकता है, एमोलियंस हो सकता है. तो पहले कौन सा टॉपिकल एजेंट्स हम यूज कर सकते हैं? एनी टॉपिकल एजेंट दैट कम्स टू योर माइंड. टॉपिकल एजेंट मतलब दिस कैन बी स्टेरॉइड क्रीम्स. ओके, दिस कैन बी स्टेरॉइड क्रीम्स. जैसे हमारा बीटा मेथासोन हो गया, all those things, clobetasol, all those things are steroid creams. Now, other than steroid creams, we can also go for vitamin D analogs. That is also available as cream, like calcipotriol. Example, calcipotriol. So first thing is topical agent. अभी topical agents के साथ the second treatment modality what we can use is phototherapy. Phototherapy. Now, लास्ट टाइम जब हमें मिला था वो विटिलिगो का पेशेंट, तो विटिलिगो के केसेस में हम कौन से फोटोथेरापी कर रहे थे? सो व्हाट वाज द यूवीए फोटोथेरापी दैट वी कॉल्ड? यूवीए फोटोथेरापी, एनी आइडिया? इट इज कॉल्ड एज प्यूवा, है ना? प्यूवा, दैट इज सोरालन प्लस यूवीए. एंड वी कैन ऑल्सो गो फॉर नैरो बैंड यूवीबी फोटोथेरापी भी कर सकते हैं. Correct? So after this UVA and UVB phototherapy, then already topical agents के बारे में बोला, है ना? और उसके बाद we have added phototherapy भी हो गया. And phototherapy के बाद now we are going to use systemic agents. Systemic agents मतलब it can be either a tablet or it can be an injection, है ना? So in systemic agents, the most important one that you should write down is methotrexate. Methotrexate. The very, very important one, methotrexate is used for the management of psoriasis. In some cases, if methotrexate is contraindicated, we can also use cyclosporin. Cyclosporin can also be used in systemic agents. Now, in systemic agents, what we can do is, after systemic agents, what are the other things that you can add on? Because for your exams, you can get many other bonus marks if you add the latest drugs or biological agents. So please always try to write down biological agents at least by its name, because there are a lot of biological agents which can be IL-12 or 23 inhibitors, IL-17 inhibitors, PDE inhibitors, etc. So let us see some of the names. I'll give you a simple way how you can remember some of the names. अभी जैसे हम बोलते हैं vowels. What are the usual vowels that we learned English language में? What are the vowels? A, E, I, O, U, right? So here, please remember the first three vowels: A, E, I. Okay, A, E, I. Okay, so this one we will learn two times. Like what is A, E, I? I'm just writing you the names of A, E, I. Okay, A. What is A, E, I? A stands for adalimumab. Okay, adalimumab हो गया one thing. Etanercept. etanercept is going to be the second one. Infliximab is going to be the third one. So please remember adalimumab, etanercept, infliximab, AEI. But I said AEI two times. There is one more AEI. AEI. Okay, what is this AEI? This is going to be alifacept. Alifacept is going to be one. Ifalizumab is another one. Ifalizumab is going to be another one. And the last one is going to be itolizumab. So I don't know how far it is going to be easy for you to remember all these things, but please remember adalimumab, etanercept, infliximab. All these are TNF alpha inhibitors. Okay? AEI, adalimumab, etanercept, infliximab. The same AEI one more time. This is going to be alifacept, SCPTA. Alifacept, ifalizumab, and itolizumab. And also, please try to remember one more, that is USA. Now, what is USA? So these are the last three biological agents that you will remember. Okay, last three. Now, USA matlab, U stands for, any idea what is U? U stands for, anyone who would like to answer in the chat box? USA कौन सा है? U stands for ustekinumab. And S stands for secukinumab. And A stands for apremilast. A stands for apremilast. So these are the few of the biological agents that you can remember, because these days कोई भी psoriasis patient में more than कोई methotrexate, cyclosporin ऐसा immunosuppressants के जगह पे, it is more likely that you're going for a biological agents, especially if the patient is able to manage the finances or the cost of this treatment. Okay, adalimumab, etanercept, infliximab, alifacept, ifalizumab, itolizumab, and USA, ustekinumab, secukinumab, and apremilast. Okay, all good? Okay. So that is about the management of the cases of psoriasis. And in the treatment part, just write down one thing, a very important note. Systemic steroids are contraindicated in psoriasis. Can anybody tell me some of the examples of systemic steroids? Any examples of systemic steroid? Systemic मतलब जो टैबलेट फॉर्म में मिलते हैं या फिर इंजेक्शन फॉर्म में, whatever is it, systemic steroids are contraindicated. अभी कौन सा systemic steroids का नाम पता है आपको? Systemic steroids मतलब, yeah, systemic steroids, it can be prednisolone, dexamethasone, isn't it? Betamethasone. So all these tablets, if you take, what will happen? The patient can develop von Zombush reaction. याद है? Von Zombush reaction, because some time back I mentioned the von Zombush reaction is usually seen in a patient who was treated with systemic steroids. That is why I said systemic steroids are contraindicated. So this is going to be contraindicated. Okay? So please remember that very important point also. So now let's go to the next topic. अभी अगला टॉपिक है lichen planus. ये जो psoriasis है और lichen planus है, so most of the features are opposite to each other. So whenever you learn about psoriasis and lichen planus, try to learn it together, क्योंकि काफी सारी चीजें हैं जो exactly opposite है. So we'll see about it. So first thing is that we are going to see what are the type of questions. Either it can be direct, tell us the clinical types and management of lichen planus. So that is going to be a direct question. Or they can ask you discuss the etiology of lichen planus and the oral manifestation of lichen planus. That can be another one which can be asked. Or clinical scenario भी हो सकता है, जैसे a 40-year-old patient with violaceous plaques. Okay, ये जो टर्मिनोलॉजी है वायलेशियस। वायलेशियस मतलब कौन सा कलर है? पर्पल कलर। अभी जो सोरियासिस में व्हाट डिड वी लर्न? सोरियासिस जो प्लेक्स होते हैं जो एक्सटेंसर सरफेसेस में, व्हाट इज द कलर ऑफ सोरियाटिक प्लेक्स? कलर ऑफ सोरियाटिक प्लेक्स, सोरियाटिक प्लेक्स is red in color. So erythematous plaques मतलब psoriasis, whereas purple or violaceous plaques मतलब lichen planus. Remember this point. Purple color मतलब silvery is actually scaling. Okay, red color erythematous plaques. Plaques का color is red. स्केलिंग ए सिल्वरी व्हाइट कलर किस वजह से? बिकॉज ऑफ द स्केलिंग, ठीक है? सो डोंट गेट कंफ्यूज बिकॉज ऑफ दैट। कीप दिस मैजिक पॉइंट इन योर माइंड, रेड एंड पर्पल कलर, रेड एंड पर्पल कलर, ठीक है? So now let's move and see how do we write answers when it comes to lichen planus. Okay, lichen planus answers. So now let's see how are we going to manage it. So in the lichen planus, what we are going to do first is, in lichen planus, again we go for the definition. What about lichen planus? Again, it is going to be chronic, acute or chronic? Chronic. So we will give a short introduction that lichen planus is a chronic. So what is it? Chronic, just like the psoriasis, this is also a chronic inflammatory condition affecting the skin, nails, mucosa, and the hair. Okay, skin, hair, nails, mucosa, all these are affected because of lichen planus. That is the first thing that you're going to write down. Okay? And then along with that, what did I tell you? Every time along with the introduction, please mention कि patient usually कैसे present करते हैं along with lichen planus. So patient complains of itchy purple colored plaque lesions over flexural surfaces. So please, when you learn this subject, try to compare and learn. क्योंकि psoriasis में the patient presents with red color plaques, यहाँ पे purple colored plaque lesion हो गया. Psoriasis में patient usually presents with lesions over extensor surface और यहाँ पे हो गया flexural surface. Okay, हो गया two differences, correct? So now let's see what is the etiology behind lichen planus. Now, what causes this lichen planus? So, lichen planus is again going to be immune mediated disease. So, just like what we have mentioned in psoriasis, there is an immune mediated thing that is going on. And what cells are usually implicated here? There is a T cell mediated cytotoxic reaction. There is a T cell related cytotoxic reaction that happens here. And other than that, there are multiple triggers also. Now, what is going to be a trigger? A trigger can be some infection, a trigger can be some drugs, etc., isn't it? So here, please mention that the trigger can be a infection like hepatitis C. Okay, or this can be due to some drugs also, like a patient is taking a drug like NSAIDs हो गया, ACE inhibitors हो गया, beta blockers हो गया. So all these things can also be a trigger for lichen planus, or it can be dental amalgam. Very good. So I like this answer because Shiv, all of you are answering. So dental amalgam. And this dental amalgam, this is for what thing? The dental amalgam for oral lichen planus. Oral lichen planus. So all these can also be the trigger when it comes to lichen planus. Clear? So collect, it should be mostly hepatitis C than B. So you can keep it both, but then hepatitis C would be more specific here. Okay? So now let us move to the various clinical features. Now, clinical features, before we write about any of the clinical features, there are multiple P's of lichen planus. So, who can tell me what are the 5 P's of lichen planus? Acha, before mentioning, it is already there in the chat box. So, there are 5 P's of lichen planus. That is going to be a first point when it comes to clinical features. So in the clinical features, what you can write down is what are the different P's. The first P, it stands for, what is the first P? Pruritic, purple colored. What is the next one? Pruritus means itching. P for purple colored. The next one is polygonal. What is the next one? Papules and plaques. So that is how you mention about lichen planus. So there would be pruritic lesion, purple colored lesion, polygonal lesion, papules and plaques. That is how it is present. The second important point is this is seen over flexural surfaces more commonly. And what do you have to say about the scales in lichen planus? I'll just zoom this image for all of you. So just see this image and you can see that there is some whitish lines over these lesions. So what do you call for this whitish lines or white lacy pattern that you can see over these lesions? Anyone? This has a typical name, and this name it starts with W. I guess you must have heard about it. This is called as Wickham's striae. Wickham's striae. So what is Wickham's striae? So these are white, lacy, reticulate pattern over the lesions. So that is called as Wickham's striae. Very important terminology. Wickham's striae, very typical for lichen planus. Is it clear? Very good. Shiv, Fatima, Kalai, all of you are answering. So all these things are right. Now, coming to oral lichen planus. Why is oral lichen planus so important? Why does the examiner always think that whenever they ask you regarding lichen planus, they always want to see that you mention about oral lichen planus? Because whenever there is a oral lichen planus, this usually presents with something like this. I'll zoom this image for you. Can you see these whitish lesions? So these whitish lacy reticulate lesions, they are again called as Wickham's striae. So you can see that Wickham's striae in the oral cavity. And please try to mention one thing. Very good, Shiv. That is the right answer that I'm waiting for. So this is a pre-malignant lesion. So this is going to be a pre-malignant lesion. So any lesion, like be it after chronic smoking or using pan and all those stuffs, or even with lichen planus, what is the patient going to be at the risk of? Is the patient going to be at the risk of an adenocarcinoma? Is the patient going to be at the risk of a squamous cell carcinoma, malignant melanoma, basal cell carcinoma? What is it? Very good, Shiv. So this is a pre-malignant lesion to squamous cell carcinoma. This is what is very important for all oral lichen planus. So please do mention this answer whenever you are writing any answer about oral lichen planus. Other than that, in lichen planus, there can be nail involvement. So in the nail involvement, the most important finding that you can write down is pterygium of the nails. So this is called as the pterygium of the nails. So what happens is in this finger, over the nails, you can see there is a wing shaped extension. So whenever there is a wing shaped extension over these nails, this is called as, hello, am I audible? So I think there's a short disturbance in the class. So can you please confirm if I'm audible? If anybody could confirm if I'm audible and visible, I can continue. I think the live just got a bit interrupted. Yeah, yeah, I can. Okay, fine. Thank you so much. Thank you for confirming. So that is about the involvement of the hair. See, as you have already mentioned in the chat box, there are different types of other findings. Like in the nails, there can be thinning of the nails, there can be tracheonychia, there can be pup tenting. But please, when you write a short note or anything, or generally the clinical features of lichen planus, please try to be very precise. Please make sure you write all the 5 P's of lichen planus. Also mention that it is commonly seen over the flexural surfaces. Okay, this is going to be very itchy. That is why I mentioned that this is going to be pruritic. And then also please mention about the oral lichen planus, where this is going to be pre-malignant to squamous cell carcinoma. In the nails, there are many other findings. So if you just want me to write it down, I can just write it down as well, along with pterygium. So pterygium, please repeat. Yeah, pterygium means in the nails, you can see that there is a wing shaped extension over the nails. This one is called as pterygium. So other than pterygium, there are many other findings like up tenting of nails, thinning of the nails, etc. So all these are additional findings that you can see. Okay. Yeah, Fatima, I'm just repeating all those nail findings now. Pterygium of the nails हो गया एक, फिर हो गया pup tenting. Pup tenting मतलब the nail will look something like this, just like a tent. Pup tenting of the nails. Thinning of the nails is another one, and there are many others. Tracheonychia and all. Tracheonychia. So just try to remember few of the nail findings. Tracheonychia, where all the 10 digits, all the 10 nails are going to have some disfiguration. So all those things can be seen. And when it comes to the hair finding, because we learn a lot of diseases which is going to affect or having a alopecia. But here, what is going to have is, in this case, when there is an alopecia, there is no hair growth again, which means it is going to be a scarring alopecia. That is another very, very important point that you will remember. Clear? Now coming to the histopathology. Just like how we have done the histopathology for psoriasis, here also you can remember few of the histopathology features. So what are the histopathology features that you can remember is, there is no, no, no. Don't get worried when you see any of these nail findings. Sometimes what happens is that nail findings are very unspecific. Okay, so if any of you is finding that चलो मेरे nails में pitting है, या फिर in my nails I can see that there is some tracheonychia, disfiguration, all these things, do not panic. ठीक है? So many of the times it can be non-specific, but it is always better to get it tested. Just to get it tested. Clear, Shiv? So, so now going towards the histopathology. In histopathology, you can find a wedge shaped hyperkeratosis and hypergranulosis. So what you can write is, please mention this wedge shaped. That's we're going to be very specific. So wedge shaped hyperkeratosis and hypergranulosis can be seen. You can see something called as cavity bodies. Okay. So you can find cavity bodies. So these are apoptic keratinocytes which you can find. Okay, so that is going to be another finding. And along with those findings, you can find some lymphocytic infiltrates also. Lymphocytic infiltrates can also be seen. Okay, and what happens here is there is something called as rete ridges. So these rete ridges, they become something like this. So this is compared to a sawtoothing. So this is called sawtoothing of rete ridges. So all these things can be seen. Okay, all these things can be seen. Yes, interface dermatitis. Interface dermatitis is excellent one because that can also be seen because most of the changes you can see somewhere around the basement membrane zone. Okay, all these things can be seen in the histopathology of lichen planus. Now coming to lichen planus, what are the differential diagnoses that can come to your mind? Any differential diagnosis? Anyone? Yeah, correct. Max Joseph space is the liquefactive degeneration that you can see in lichen planus. Completely agree with you. Now coming to the differential diagnosis, what are the diseases that it can resemble? First, once again, this can be something similar to pityriasis rosea, can be something similar to pityriasis rosea. Another disease where you can find a purple colored erythema. Where can you find purple colored erythema? Any disease? Yeah, psoriasis can be one of the differential. Purple color, this can be anyone purple colored erythema, which can be compared to a heliotrope flower. This is called dermatomyositis. Okay, dermatomyositis. So all these things can be a differential diagnosis of. And when it comes to oral lesions where you get this white lacy lesion, so there you can also add leukoplakia also. Leukoplakia for oral lichen planus. That can be a differential diagnosis. Clear? So now let's move into the treatment part of lichen planus. So how do you manage lichen planus? Lichen planus, again, since it is going to be a immune related wala thing, so we always will again stick on to our rule. What was our rule? For anything in dermatology, we will always write about topical agents first. After topical agents, only then we write about systemic agents. So this is going to be our rule for all dermatology cases. Okay? So for topical agents, what we can do is we can again go for corticosteroid creams. So we can go for corticosteroid creams. Or we can also go for one more thing, which I have already discussed in the last class. Whenever you don't want to use the steroid cream for a long time, there is one alternate choice for us. That is calcineurin inhibitors. Calcineurin inhibitors. Does any one of you remember the names of calcineurin inhibitors? Like, for example, in the last class we discussed calcineurin inhibitors. We spoke about it in when we discussed about vitiligo. So, calcineurin inhibitors, any idea? Yeah. So, for example, this can be pimecrolimus or tacrolimus. Tacrolimus. So all these things can be used. Okay, very good. Good answers. Now, the second one, which you will be giving a subheading, that's systemic agents. So systemic agent कौन सा हो सकता है? Because we have to reduce the immunity. There is an attack on our immune system. So obviously we go for oral steroids or other immunosuppressive agents. Immunosuppressants. So what are the other immunosuppressants that is usually used? It can be either azathioprine or it can be cyclosporin or it can be mycophenolate, etc. Okay, so all these other immunosuppressants can also be used. But please, when you just write down regarding the management of lichen planus, you can also add one more very important sentence here, that this condition can be self-limiting. So this can be self-limiting. So what is the meaning of self-limiting? कि कोई ट्रीटमेंट देने की जरूरत ही नहीं है ना? तो दिस कैन बी सेल्फ लिमिटिंग. पर आप इमेजिन करो कि एक पेशेंट है जिनको एक प्रोराइटिक या मतलब इच्छी वाला लीशंस है बहुत सारे, okay, over the trunk. But can we just wait and watch? We definitely will have to go for treatment, isn't it? So that is why this self-limiting wala thing is only theoretical. In most of the cases, we will have to go for treatment when it comes to the practical aspect. So the self-limiting, this usually takes somewhere around 6 months to 2 years for us complete resolution of symptoms. So it takes around 6 months to 2 years for a complete resolution of the symptoms. So that is how we manage this case of lichen planus. So that is all of it regarding the important topics in dermatology. So what we have done in the last two lectures is that whenever we are learning about anything in dermatology, we are always going through the introduction part. We are giving a proper introduction about the disease. We are also mentioning what is the clinical features of the disease, and then clinical features. Please try to learn every clinical features with images so that the photographic memory will always be working and you'll be able to write a good story based on these images. Okay, and then please try to give yes, because Shiv, what is happening is when we go for a treatment regarding the pigmentation, it is something called as a post-inflammatory hyperpigmentation. So in most of the cases, it's not only in lichen planus, in most of the inflammatory conditions of the skin, when it heals, it can give you a post-inflammatory hyperpigmentation, which usually fades away over a period of time. Sometimes what happens, we may have to give some skin lightening agents as well, especially if it is over the exposed areas, like over your face, over your neck, over your forearm and all. So if it is exposed area, we can give some skin lightening agents as well. Clear? So that is it. And then please try to follow the entire route, like giving introduction, etiology, clinical features, differential diagnosis and management. And don't forget, you have to go through the app, just see what are the commonly asked questions and try to have the same approach. If there is any difficulty, please feel free to answer. And please reply, how do you differentiate hypopigmentation due to pityriasis versicolor or pityriasis alba on a child's face? Okay, so let me just answer some of the queries that you have. The first query that I'm going to answer is, there is a patient who is having pityriasis versicolor versus pityriasis alba. So first I'll answer this question for Shiv. Okay, so pityriasis versicolor and pityriasis alba, if it is happening over the face of the child, this is the question. Okay, so in the face, both these things can present to you with a hypopigmentation. So what I can easily do is, I will ask the patient to get a simple test to be done. What is a simple test that I can do? I will ask the patient to do a KOH test. When we do a scraping over these lesions in a KOH, what happens? The KOH will be positive, that is potassium hydroxide test will be positive if there is a fungus. Where is the fungus? The fungus will be present if it is pityriasis versicolor, because we can see spaghetti and meatball appearance, whereas there will be no fungus when it comes to pityriasis alba. Is that clear, Shiv? Okay. And Helix is asking, can erythema marginatum rheumaticum be a differential diagnosis in psoriasis? See, you can add this as a differential diagnosis, because any of the disease where you get a plaque kind of a lesion, be it single or multiple, can be a differential diagnosis and the examiner cannot mark it as a wrong answer. That can be okay. But the difference is, erythema marginatum rheumaticum, this is actually a transient lesion. Transient का मतलब क्या है कि it comes and it disappears, है ना? तो यहाँ पे क्या होता है, in rheumatic fever, in rheumatic heart disease, when you get this erythema marginatum, you see multiple round lesions, but some of the lesions would be disappearing, some of the lesions would still be present, but then clinically it can be a differential diagnosis for psoriasis. So anything else? Any other queries which you may face while learning dermatology? I'm happy to answer if you have. So pityriasis versicolor has fine briny scales versus alba no scales. No. Here I would like to correct you. Please remember the name pityriasis. ये जो P है ना, जो pityriasis. Pityriasis itself means scaling. So please don't write that pityriasis alba does not have scaling. That is wrong. Pityriasis versicolor, pityriasis rosea, pityriasis alba. All these conditions, even pityriasis rubra pilaris. The name is pityriasis because pityriasis means scaling. Okay, where you do not have a scaling is a disease where like indeterminate leprosy. So probably you are confused based on that. Okay. So any other queries? So if there is no other queries, just rock your final year exams. Okay. So just pass these exams with flying colors and do let us know as well. And if there is anything that you would get a support, you don't hesitate to inform us. We always will be there to help you. Okay. Thank you so much. Wishing you all the very best and we will stay in touch. Thank you so much for your listening and being a very, very interactive crowd today. Thank you.